discuss some of the complications related to seizures. We're going to look at some diagnostic tools, ways to identify different ones. We're going to review some of the collaborative care and nursing care of patients with seizures. And we're going to discuss some of the gerological conditions related to seizures. So, just a general question. I always like to know, just out of curiosity, who here, if you don't mind me asking, who here has seizures and or epilepsy, or has a family member or knows of somebody close that has it?
Anything?
Just 2, 3, 4. Okay, wow, that's really not, I thought it would be more common than that. All right. What they are? Basically, you have uncontrolled electrical discharges in the brain that are just firing, okay? They don't know where to go, they're just kind of all over the place, okay? Can happen instantly, okay? Sometimes you'll have patients that will have an idea that one might be coming on, okay? We'll kind of talk about that a little bit. Could have a cause. Sometimes it could be related to certain medications, could be a certain condition, could be trauma, and we'll kind of go through that. I know in the news there's been a lot about PTSD, okay? We're having a lot of patients that are really struggling with traumatic brain injuries and having subsequent seizures. And then there also might be some sort of autoimmune deficiency. So you don't need to know the details of this. I just want you to understand that there are dozens of causes of seizures, okay? You could have some metabolic causes, okay? You could have a patient that is in acidosis. They could be suffering from severe alcohol or drug withdrawal. You'll see that on the neuro unit. A lot of times, patients that are having really, really horrible time withdrawing from alcohol or drugs will have pretty severe seizures. You'll see that. Somebody with hypoglycemia, right? Low sugars, okay? They could be having a seizure as well. All different kinds of reasons. Outside the brain in particular, these are some of the more specifics, okay? And we're not going to get into any of those specifics. We're just going to talk about generalities of seizures right now. So this reiterates just what we talked about, okay? It could be from birth injury, birth defects, birth trauma, trauma head injuries. That's why we're always making sure that we're wearing helmets when we ski, when we bike, all that sort of stuff. Genetic factors. The one thing I'll point you to, the common causes of epilepsy in people over 50, stroke. Stroke is the most common cause. So let's talk about the 3 major classes. The more I went through this, the more I tried to cut it down. So we're going to be just very, very specific about filling in these blanks, okay? Generalized onset, okay? So basically you have 3 major classes: generalized onset, focal onset, and unknown onset, okay? So first let's talk about generalized. That's going to be the most common, okay? As we talked about earlier, it involves both sides of the brain, okay? Usually, what happens with their loss of consciousness? Usually it's loss of consciousness for a few seconds, okay? A few seconds to several minutes. Focal onset, for a simple focal onset, okay? Do they have loss of consciousness? They do. They're aware. It could be like more of a dreamy, but they have their conscious, okay? They are aware. Complex, okay? Complex focal onsets could be altered or impaired awareness. Okay. We talked about the postictal phase. Remember that? Okay? You could have a patient that is fully unaware, or they could be quite aware of what's going on after they've had a seizure. But just so you know that phase is postictal phase, and that's what happens as the seizure subsides and as it clears up. There are 4 different phases. You'll see that in the book. You don't need to know those. I just want you to focus on that last one, okay? So let's break some of these down. generalized onset seizures, okay? Tonic-clonic is probably the one that you're most familiar with. They used to call it grand mal seizures. I don't think that you'll hear that very often. It is characterized by a loss of consciousness and falling to the ground if the patient is upright. Who was it that did the tonic-clonic seizure for us? Shama, right? Okay, so what does tonic mean?
It's body stiffens.
Body stiffens, right? And the clonic portion is basically the jerking of the extremities. Sometimes you'll have the cyanosis, so basically they need oxygen, right? I talked about how quickly some of the kiddos that I've taken care of, they'll have blue around the mouth, so they'll be cyanotic around the mouth. Could have foaming. That's why we're using that Yankauer. We want to make sure that we're making sure that airway is clear. So all we're doing is kind of suctioning around the mouth. Sometimes you'll have some kind of weird symptoms, cheek biting, lip smacking, those kinds of things. They could be incontinent. We've already gone over what the phase is called after the seizure has ended. That's the postictal phase, okay? Sometimes patients will have muscle soreness. Sometimes they'll be excessively sleepy. It really, really varies, okay? As I said, sometimes they will know when a seizure is going to start before it happens, okay? They may not feel normal for hours or even a couple of days before it's happened. Do they have memory of the seizure? No. No memory. That's really what classifies general seizures. This is what you'll see with a lot with kids, those absent seizures, okay? Basically, it's really kind of scary because you could have a child that's having these and nobody really notices, okay? They could be having these staring spells, and that's what they're called. That's one of the typical symptoms, is kind of like a daydream or a staring spell, up to 100 times an hour. So you have this poor little kid that's missing a huge amount of content that's being presented, and everybody thinks he's just not paying attention. Okay, so generalized seizures, we're going to continue with this, okay? So you have a typical, atypical absent motor seizure, okay? It is characterized by staring spells, and it also has other signs and symptoms. So this is the one that you could see some eye blinking or jerking movement of the lips. Sometimes it can be very, very fast, 10 to 30 seconds. It usually happens, kind of continues in as you grow older. Okay, still working on generalized seizures. You have myoclonic, atonic, tonic seizure, and clonic seizure. As you can see, the clonic seizures are pretty rare. But just in general, if you have a patient that is having a seizure, we've all talked about this. What is the greatest risk for what kind of injury? Head injury, right? Okay, so that's why we talk about increased intracranial pressures and seizures in the same time, okay? Because if you have somebody that has severe head injury, more than likely they're going to have increased intracranial pressure, and that can happen just like with the atonic seizure. And it's really scary if you've ever seen it before, but basically person's just walking along and they just drop, okay? Let's move on to focal seizures. As I said, I'm just going to go over the highlights because that's what you all need to know. Okay, you have simple focal seizures. This one, the person remains aware, okay? Totally conscious. It's really kind of strange. I've had patients explain this to me, and it just almost seems like an out-of-body experience, but they really do have really incredible feelings, like joy. 1 minute they're very, very happy, the next minute they're very, very angry. It's just all part of it. And they can hear, smell, taste, see, or feel things that aren't real. It's almost like putting on those, the VRBs, the visual things. Yeah, that's about as close as I can think to describe it. These are some of the more prominent signs and symptoms that you'll see with complex focal seizures, okay? They have an altered or impaired awareness, very dreamy, okay? Let's just kind of run through these with some of the signs and symptoms. What happens with their lips?
Smacking.
Smacking, okay? What are automatisms?
It's like the lip
Repetitive.
smacking and the picking, it's like, is it involuntary twitching almost? It's not
Yeah.
twitching, but
Yeah, it's kind of like they're involuntarily doing little things and not really knowing they're doing it. Like, they could be unbuttoning their shirt or doing like like repetitive movements without really knowing that they're doing it. Okay. Do they remember what they're doing? No, they don't. Okay. That's really kind of scary if you have an adult that's having a complex focal seizure and then all of a sudden they're half dressed and they don't realize that they've done it. Okay. The seizures can last, there's just multiple amounts of time. There's such a spread there, okay? And they can be confused, okay? So the important thing to recognize here is that if you have a patient that is having these, well, let's just say you're on the street and you notice this, you might think that the patient is having a drug interaction, or maybe they're drunk, right? So as nurses, we're always on the lookout for, okay, let's sort of evaluate the situation and figure out what's going on, okay? We're really lucky in the hospital setting. We know if they've got that diagnostic test that says, hey, I have epilepsy, I've known to have seizures, this is what I do, okay? So just be aware. So these are these kind of like signs and symptoms we just talked about. Chewing, these are the complex focal automatism. So chewing, lip smacking, repetitive dressing, undressing, fumbling with buttons, just really, really bizarre. Sometimes you'll see them doing this, kind of like a pill rolling. Okay, I don't know if you've all ever seen that, but it's literally they act like they're rolling a pill. Okay. So pseudogenic seizures. This one always makes me really, really sad. And quite frankly, I didn't realize that they were a thing until I had a patient, I had a student that had a patient last semester that had these pseudogenic seizures. And basically what had happened, she was in her mid-30s and just had really a traumatic life, sexual abuse, physical abuse, emotional abuse, and they couldn't figure out why she was having all these seizures. Okay, these are pseudogenic seizures. Basically, her body is just, that's how she is responding to the overwhelming grief and desperation that she's feeling. And that was how her body was responding. She was having these seizures. But there wasn't anything that the doctors could do, okay? And she had been in the hospital for a week. Her family really wasn't taking care of her. It was really, really sad. So patients that frequently have a history of emotional abuse, physical, it could be PTSD, okay? Anything that you can think of that has a traumatic effect, really that could be that individual that's going to have those psychogenic seizures.
There's no treatment for that?
Just therapy, yeah. Hey, who answered this question? Effects on lifestyle is the most common complication of epilepsy. Huge, okay? You would think it's all the other things, but when you put it all together, it has a huge effect on your lifestyle. So if you have epilepsy, my sister actually, she had a lot of trauma and she started having the pseudogenic seizures. And she was a FedEx driver. They took away her license. So how does a driver operate? How do they function if they're having seizures? So in the state of Virginia, you couldn't drive for over a year if you had a documented seizure, okay? So we talk about all the complications, but when you really, really think about it, think of all the little things that go into it if they've been diagnosed with that. This is the worst of the worst, okay, if you can think of it that way. Basically, it's a constant seizure that lasts greater than 5 minutes. So these are the ones that you will see an order for. The doctors say, okay, if my patient is having a seizure that is lasting longer than 5 minutes, you will give Ativan, or you will give some sort of high dose of something that the doctors have prescribed. Okay, You don't need to know the medications at this point, but I just want you to know that this is a constant seizure that lasts more than 5 minutes, okay? Or a set of constantly reoccurring seizures in rapid succession. So basically, you could be timing it, but they're so close together, you may not even recognize that they've stopped, okay? And it just continues and continues and continues, okay? The worst part about this is that they could die, okay? They could die if that seizure is not stopped, okay? Basically, the neurons just are so exhausted that they give out, permanent brain damage. Your diagnostic studies, it seems like everything we talked about today, neuro-wise, is all about the CT scan, so I'm not gonna drill into the contrast, okay? Obviously, though, we're making sure that we get a really thorough patient history. We want a description of the seizures. So if you have a family member that's having a seizure, newly diagnosed, the doctors will ask a bunch of different questions. And if you're a nurse in the hospital and you're witnessing a seizure, he's gonna ask you those same questions. So unfortunately, I couldn't take a video of a patient having a seizure in the hospital. But if you are out and you have a family member, okay, that's having a seizure, you can take a video of that, and it'll really help diagnose the origin of the seizure, okay? So some of the things that the doctors might ask you is A, timing, how long did it last, okay? Did they have a postictal phase, and how long did it last? Did the eyes deviate to the left or to the right? So I don't know the mechanics behind it, but essentially if you're able to tell the doctor where the eyes go in one direction or the next, that really, really helps them to determine the origin of it, okay? Those are the biggies that the doctors will ask. Oh, and did they require oxygen? Did they have any cyanotic episodes? Okay. Drug therapy. As I said, I don't want you to focus on the drugs, but we did talk about the one Dilantin, okay? It talks about all the problems with the gums and the bleeding and the inflammation, okay? Obviously, the goal is to either stop or minimize, and or both, the number of seizures, okay? They can be toxic to the liver, so you're always looking out for that. Medication, education, multiple side effects. Another big thing, and I forget who mentioned this, really important, anti-seizure drugs should not be discontinued abruptly, okay? This can actually make a seizure happen. We talked about the Dilantin, and certain foods will contradict the medication action. So Tegretol, which is a anti-seizure medication, interacts with grapefruit juice. You'll learn that farm if you haven't already. I pull this out because you may have a really cool opportunity to see one of these, okay? I see this a lot with kids. Basically, it's a non-pharmacological intervention for kids that is called a vagus nerve stimulator, so a VNS. And adults can have this too. So basically what happens is that when a patient is having a seizure and they have one of these, they will have a magnet that's posted at the top of the bed, and all you have to do is run the magnet, just kind of hover the magnet over the generator, and it stops the seizure. It's absolutely fascinating. So if you have a patient that has a seizure history and they have a VNS, make sure as nurses, you know where that magnet is. It should be posted above the bed. And if that patient has any procedures in the hospital, you're sure shooting, you know you're taking that magnet with you, right? Because as soon as you get into IR, so interventional radiology, or they go down to a CT scan, sure enough, they're gonna have a seizure and you're not gonna have that magnet. Okay, it's really, really cool how it works. So it just works on the vagus nerve stimulation, just a tiny implant. You've got a bunch of leads there. So yeah, very cool. And diet helps as well, obviously, but, and I'm not sure the parameters behind that, but that's all for provider preference. Okay, almost done here, guys. So the nursing process, okay? You know the questions to ask, okay? You know this, all right? As I said in the beginning, there's a lot of precipitating factors that can cause seizures, okay? You can run through the list. We already talked about this, okay? safety measures. What would you recommend? How would you do that? If you see it, you guys talked about it, okay? It was on the board on that far left side. So you've got your room set up, and now you've seen it, now you've got your steps. Okay, let's see if we missed anything. Room setup. So privacy, oxygen suction, side rails, loosened clothing, pillow under the head. Might want to get that out of there depending on how they're lying. Patient in the side lying position, and the side rails up. So and they have a little thing down here that says padding not shown. You always want to make sure there's pads. And that is all I got. That's it.
That's